All right, I think we'll go ahead and get started. I'll keep an eye on the waiting room as well. So thank you all for being here this afternoon. Happy Valentine's Day to everybody. Those of you that have not gotten a chance to meet Ruben yet, Ruben is our wound care guru. He's got 20 plus years of wound care experience, primarily here in the San Antonio, Texas area. If there's a wound, he's probably seen it. He works in the hospital systems, so he gets to see a lot of really cool stuff. He uses a lot of graphs on a regular basis. And so he's going to give you guys kind of a firsthand look. Today's specifically going to be over diabetic foot ulcers. He covered kind of a vast overview of everything last time. We're going to start diving into specific wounds now. These diabetic foot ulcers are primarily what most of your podiatrists are seeing. They're very common wounds on the diabetic realm of things. So these wound care grafts are used pretty often in these kind of scenarios. So Ruben, I'm going to turn the controls over to you now, and go ahead and take it away. Thanks again.
Hey there, everybody. Let me get this going here. Everybody, can y'all hear me and see this okay?
I can hear you.
Okay.
And I can see everything. I'm assuming
Great.
everybody else can as well.
Great.
Yep.
Okay. Awesome. All right. Well, let's get into it. I want to talk about the diabetic foot ulcer. So here we go. So in order to talk about diabetic foot ulcers, we got to talk about diabetes. So let's kind of get a brief overview of diabetes and what it is. So diabetes is a chronic disease that occurs when blood glucose or blood sugar is too high. And the glucose is the main source of energy, and it comes from the foods we eat. When our blood sugar goes up, the pancreas releases a hormone called insulin, and that insulin helps the glucose get into our cells and to be used for energy. Okay. However, with diabetes, the body does not make enough insulin or cannot use it well enough, and causes too much glucose to stay in the bloodstream. And these high blood sugar levels are what causes organ system damage. So with diabetes, there's three types. There's your type 1, which the body attacks itself by mistakenly destroying the cells that produce the insulin in the pancreas. A lot of times this is referred to as juvenile onset in the past. And then there's type 2 diabetes, which is the more common, and the body does not use the insulin well enough. The excess consumption of sodas, all the stuff we shouldn't be eating, excess weight, and lack of physical activity. This is what causes the insulin resistance. And then thirdly, which not everyone considers, is gestational diabetes. And this occurs with the pregnant women who did not previously have diabetes that went on to develop diabetes. And this can go away after they deliver. However, this increases their risk of type 2 diabetes. And I also asked this question of my women in my primary care side of things. So I definitely have a high alert on that. Oh, let's see.
Yeah, Ruben, we can see your main screen, but it just shows like the diabetic foot ulcer. Nothing has advanced quite yet.
Let
So I don't know if
me try that. Is that better?
Nope, still see the same. There it goes. Now it's starting to move. We see the diabetes, kind of the general overview there.
How about that one?
Still on just diabetes. There we go. Now we're seeing your mouse move.
Okay, are you seeing this slide now?
Yep, you're good now.
Okay, so I guess it likes it this way. Okay. So we talked about the three types of diabetes. Then the diabetic foot ulcer is the more common complication of diabetes. And this happens when there's a higher than normal glucose level in the blood. This leads to damage of the protective sensation in the patient. So they start to develop this neuropathy where they lose, when you kind of step on a tack or something sharp and you're like, ow, well, they lose that sensation. And it also starts to gum up the blood vessels. So then you start to get poor circulation. And then with lack of proper foot care and offloading, then that's when things bad start to happen. And these ulcers will develop. So they tend to lead to bone infection or osteomyelitis if these are left untreated. And these ulcers tend to develop just from walking on it or pressure. Okay. So infection is very common, and most common organism is staph. And one practitioner cannot do it alone. It requires a team approach, such as a primary care provider, the wound care specialist, the vascular surgeon, endocrinologist. Everyone in the healthcare field is needed. So just kind of the objectives of what I'd like to do is just talk a little bit about pathophysiology and the progression of diabetic foot ulcers, some risk factors, the treatment options, and then multidisciplinary approach to optimize their care. And okay, I'm going to beat up on San Antonio for a little bit. Uh, so in a population focus, right? 1 in 6 people for San Antonio have type 2 diabetes, and 1 in 3 have pre. It is most responsible for hospital admissions than any other diabetic complication. And diabetes is the leading cause of non-traumatic amputations in the US. 5% of patients with diabetes develop foot ulcers, and 1% end up with amputations. Diabetes and overall death and mortality. Diabetes is consistently among the top causes of death in Bexar County. This is San Antonio. And it's the highest rate in Texas and the highest rate in the US. And diabetic foot ulcers can occur at any age, but are most common in patients with type 2 diabetes and age 45 and older. You kind of wonder, well, how does the patient develop the ulcer? This is the more gradual way that they get an ulcer. It's not as acute as I would typically see in the hospital. So I'll just kind of walk you through this one. Patients walking around, they don't have that protective sensation, and they have these bony areas on their foot, and so they're rubbing the foot, and then the skin becomes dry and cracked, and the feet start to crack and peel, so that callus starts to form like a little foreign body, and that causes the subcutaneous hemorrhage and eventually deteriorates and it becomes an ulcer, which opens up. And then the patient starts to develop, the plaque in the arteries because the sugar levels are too high, so that causes the vascular compromise. And then when the increased blood sugar in the body will also being prone to infection. And then you have poor circulation, which delays the healing, causes the tissue death, and then you get that gangrene that forms. And usually these ulcers develop in the weight-bearing areas, such as the metatarsal heads, which are on the plantar on the bottom of the foot, the heel, the tips of the hammer toes, and other bony areas of the foot. And part of the workup is you want to get a good patient history. You want to know, well, how long have you had diabetes? Has your diabetes been controlled or uncontrolled? And very often the patient will they try to fool you, but the blood work will prove otherwise. Do they have loss of protective sensation? And you can do a test on their feet. You just do a monofilament test and kind of touch around their foot to see if they have any sensation. You check for peripheral vascular disease. Have you had any previous ulcers before? Any calluses? Have you, how did they turn out? Did you heal up before? Any issues? And then you want to look at their shoes. That is the tell-all right there. You see these pair of shoes they're wearing. If they look old and all ragged and worn out, they're probably going to have more issues. So it kind of tells you. You can actually see holes in the shoe where they kept rubbing and wearing out, and then you'll see drainage, and that's usually where the wound is. So it's kind of interesting how that all forms. And then don't get too close because those shoes, they really smell. But that's another topic for another time. Um, so your evaluation, like I mentioned before, the blood work, the patient, I get an A1C because I don't care what they tell me their blood sugar is. This one will tell me if they're lying or not. This is a look at the blood sugar for the last 3 months. So the hemoglobin A1C is pretty good indicator of where they are with their glycemic control. And then you want to get a complete metabolic panel, a CBC, check some inflammatory markers like sed rate and C-reactive protein. At this point, if you got a good look at the wound and you can get a good deep tissue culture, then this will definitely help you direct your plan of care. And remember, deep culture is preferred over a swab culture because you want to get what's in the tissue, not what's on the surface. And then you want to get some imaging, got x-rays, sometimes give you a little more obvious look at things. If you see air in the tissue, then that means you need emergent treatment. If there's a fracture or some kind of foreign body. And obviously, if you're suspecting something, then you'll escalate it up to an MRI or a bone scan. If they have hardware, they can't have an MRI. A lot of times, if you probe the bone, that's usually a positive indicator. The bone infection. Some providers there's like two sides. It's like, well, I might probe the bone, but I don't suspect bone infection. And my thing is, I'll suspect it until you prove me they don't have it. So then I like to have imaging to go along with it. So it's just kind of a poor man's test to know is that probe the bone thing. And then some vascular studies like an ankle-brachial index or arterial Dopplers can definitely do the workup for the circulation. And then when you're kind of classifying these diabetic foot ulcers, there's this system that some people use called the Wagner classification. It's been around since the 80s. And even I use this in my documentation when I'm trying to classify this. I would kind of point this out to get a little familiar with it. Not that you're going to be using it, but these terms are common in the hyperbaric world because let's say, so here, let me go through the stages and then I'll kind of get a little more into it. So the grade 0 is intact skin with bony deformity. The grade 1 is the next step where you have a superficial ulcer. A grade 2 is a deeper ulcer involving tendon, bone, or a joint. And then a grade 3 is where you have the full thickness ulcer, but it has an abscess or osteomyelitis. Now, the grade 4 is obvious gangrene of a toe or the front half of the foot, and then a grade 5 is the entire foot. So it's pretty bad. But let me point out a grade 3 diabetic foot ulcer. That's when people are looking at hyperbarics indication. So your clinicians would be thinking, might be working this patient up for hyperbarics. So they have a wound greater than 30 days. It's this deep. If they're a candidate for hyperbarics, they're probably also a candidate for a skin graft. But we'll get into that. I'm just kind of pointing out when you hear, hey, well, do you have any patients with this Wagner classification grade 3? And then that kind of tells you, yeah, wow, this definitely patient could be a candidate for this. And then here's some pictures to kind of go with what I'm talking about and kind of how they manage it. So you see the grade 0 down here. There's no skin breakdown here. There's a little more breakdown. Here's all full thickness. And then the 3 gets down to the bone. And then the 4 and the 5. Now,
hey, Ruben, really quickly.
Yes.
The 4 and the 5. I
Yes.
mean, obviously they're going to get the foot removed and sutured back together. Would that still be a situation for a skin substitute, or they're just going to?
Okay, that's a very good question, and actually, that's perfect timing. Perfect timing. Okay.
Oh, I was going to say, okay, if you're going to get to it, then yeah.
No,
Sorry.
you're right. This, and I'm glad you brought this up because I see a patient in the hospital for the first time. They didn't go 1, 2, 3. They went 4. They came straight to me with a 4. Now, this is emergent, so the podiatrist is going to have to get in there and do an open transmetatarsal amputation, and they're going to leave those bones exposed. Okay. So they could be a candidate for graft if they're going to leave it open because it's infected. And a lot of times they'll do a delayed primary closure. So you might have a few weeks to work with doing that. It just kind of depends on the surgeon and what the plan of care is. So let me see.
No, that makes sense.
Yeah, it's I gotta get some people real quick just to make sure I'm not missing anybody.
Well, it sounds like it depends on the situation, depends on the patient, depends on the doc as well.
Correct. I have podiatrists that are a little more in tune with that, and they would do both. They would do the open TMA. It just depends on exactly the situation and if the patient's a candidate at that time, because it can be more of a, this is a life-saving issue sometimes. So they might have to disarticulate the ankle because it's too bad, and you won't be able to do a skin graft on that, or the skin sub. But it's a very volatile situation, so you just got to kind of. It's not always a slam dunk. Well, yeah, they can do a graft and leave it open, but it's a possibility because they would most likely do an open TMA just to kind of let it drain, put a wound back on it, get things to cool down for a bit, and then come back at it with the skin sub. Yes, with the amnion. So so it does, like I said, it doesn't always progress, 1, 2, 3. It's gonna go 4 and then 3 and that kind of thing. So it's interesting how that presents. And then just the management of what they see, you want to do debridement and offloading. So they like to do casting, which is great. And that also applies when you do the skin sub. You want to offload, and casting is beautiful, or some type of boot works as well. There's another classification called the UT classification system. You can be familiar with this one. I rarely see it used, so I just think the Wagner's has been the most common that I've come across. So let's get back to treatment and management. It's most important to identify infection, and let me make sure I don't have any more to add. Okay. Yeah, again, infection is the important thing. So you want to make sure there's no imminent infection or immediate infection to address. A lot of times the patients don't have the systemic infection symptoms, so you still have to be aggressive, but they may not present like they're looking septic, but it can happen. And you got to decide, well, can this patient be managed in the outpatient setting, or is this an inpatient type of setting? We need to get them IV antibiotics. We need to get them, aggressively taken care of. And then kind of understanding, well, what kind of organisms do we typically see in a diabetic foot ulcer? And this can be Staph aureus, the Streptococcus, Pseudomonas, and E. coli. And you'd be surprised, E. coli is in a lot of these wounds, as well as Pseudomonas. I mean, they're all common. It's just, yeah, it's so challenging, so challenging. They even carry the staph in their nares and on their skin, and it's just an opportunity waiting to happen for these folks, just to some kind of break in the skin, any opportunity, and it can turn. And the severity of infection, of course, determines the dose and delivery of the method of the IVs of antibiotics, whether you go oral versus IV. A lot of times we try to overtreat because we know how volatile it can be for a diabetic foot ulcer. And then again, you want to treat the underlying peripheral vascular disease because inadequate blood supply will limit the oxygen and nutrient supply. So you can't get the antibiotics to the tissue if there's no circulation. The graft won't work if you don't have circulation, those kinds of things, right? So a lot of times you'll perform local wound debridement. You want to get get a nice healthy wound bed. You could use the wound vac to optimize the wound bed, and offloading, offloading, offloading. I put that in there 3 times because that is so important and it's often overlooked. You do custom boots, total contact casting, cam boot. And I know, and if I get off on this, we basically put a cast on the patient's foot. They don't have a fracture, but they get a cast because they cannot take it off. And every week we take the cast off and we put another cast. So just so you guys understand, the boots are great, but the patient can take it off. And they're gonna take it off. And they're gonna walk without it. So this total contact casting, they can't remove it. So they're gonna do better. And they always do, but they'll figure out a way to get out of it somehow. So just I want to just be make that a point that if you can keep the patient off their foot or adequately offload it, I mean they can walk on it, but the cast is distributing the weight, they'll do better. Okay. So the idea is prevention. You want to keep new ulcers from forming, and you want to prevent worsening of the current ulcer. And how do you, other ways to offload: walker, knee scooter, wheelchair, whatever it takes. Okay.
Hey, Ruben, another quick question, really quick.
Yes, yes.
Um, so a lot of these patients, obviously once they get a skin substitute, I mean, obviously if they're not taking care of themselves and stuff like that, but are they eventually gonna get better, or is this just kind of a band-aid that continues until they figure it out, or the vascular surgeon does something or whatever? I'm just kind of curious long term.
No, I understand, and wounds are so frustrating. it's it's never perfect, right? And these patients are not the healthiest patient. But understanding that you're going to give them the best plan, the best care with the skin sub and it's actually leading to the next slide. So let's take a pause for a second on this. Let me go through the next 2 slides because I think I might address your question here. Okay.
Yeah, do your thing.
Yeah. I think I might actually get to that here.
I mean, obviously, it's like from our standpoint, we get to keep selling into a patient that needs it constantly. But it's like, I'm curious, if they have to do a better lifestyle, then they get over it and they don't use our product anymore, or is it
No,
they
they
do
need
it for the rest of their
our help.
lives?
They're going to need our help, and if you understand the socioeconomics with everything, these folks they need every opportunity of any type of help we can offer, and you'll see. There's a slide that talks about the number of applications and how we can address this. So yeah, let me get to that in a second here. So the treatment and management, we're continuing that. If the wound fails to heal in 30 days with all the previous interventions, then the patient could be a candidate for hyperbaric oxygen therapy. Now, because of low oxygen supply, it delays the wound healing, and hyperbarics increases the amount of oxygen into the plasma and not just the red blood cells. So that's one treatment modality. And then the skin subs is where we would come in next, right? Because they're a candidate at both of these phases in the 30-day window, right? And so let's talk about it a little bit. So the skin subs of the human amniotic allograft, it's the biological wound dressing derived from the amniotic membrane, contains amino acids, nutrients, cytokines, and the growth factors that make the growth process easier, right? And there was this meta-analysis done of 11 randomized trials, which confirms that, this dehydrated human amnion and chorion allografts plus the standard of care is superior to standard of care in terms of safety and efficacy. And so that was phenomenal. And to your point, we could get complete healing at 6 weeks, and they went on to heal at 12 weeks. If they didn't heal at 6 weeks, they healed at 12 weeks. And this decreased the average healing time. And the wound size also decreased, right? So compared to the average healing time of 113 days. So this is just average patient doing the regular thing, 113 days is that wound, right? Oh, are y'all seeing a change? Sorry, I don't know if, are y'all seeing this slide okay?
The skin sub human amnion one?
Yes.
Yeah, that's we're on there where it says meta-analysis.
And then we're on the next one, the skin.
Yep.
Yep.
No significant adverse events. Yeah.
Okay. Perfect. Thanks.
So it's a screen share, so we can see exactly what you see.
Okay, I wasn't sure if the I don't know, for some reason I wasn't looking out. I'm doing the right thing for you. Okay. So no significant adverse events were reported with the skin sub with the amnion, and there's no increased risk of complications compared to the control group. So it's great to know that we're not going to hurt the patient at all with this product, and it's only going to help, right? And this is the worst candidate of patient because they're have all these comorbidities, right? And so to your point where you had brought up, if we can heal the wound quicker, then we reduce the amount of complications. So a lot can happen. And I think my next slide I'll summarize that a little bit. But let's just kind of talk about the initial cost is a factor in some of these things, right? But it achieves healing about 2.5 to 5 applications in some cases, which is great. And generally we get approved for up to 10 applications per wound. And the reimbursement can definitely help in the private office or home setting. And so I moved over too much.
Hey, Ruben, another quick question. Sorry.
Yes.
I mean, this is going to come up if I'm talking to docs. Obviously, am I going to have to use this on one of my patients forever, or is it going to be, a few months and now we solve the problem and now you can go home and everything's great and obviously watch your diet and do what you're supposed to do and exercise and all that good stuff? Or is it like forever they're going to do it? Because a doc's going to be like, do I have to put this on for this patient forever? Or is it, 3 months they're good and I can send them down the road and now I love this product and I'll do it again for another patient?
Correct. Will the wound forever be healed after I put it on? A certain number of applications. If you look at their ulcer reoccurrence is high in a diabetic. So if they don't do, let's say we put 5 grafts on, you did it weekly, the patient did everything by the book. You did everything by the book. And you get the wound to close. They're at risk for re-ulcerating the same area because in my previous talk, you're only 80% as strong as you were from initial injury, right? It's never as good as your normal skin. So they can always re-ulcerate if they don't manage their diabetes and do the offloading they're supposed to. So it may not be that same spot. It could be a spot next to it or a different foot. But the good news is if you have that relationship with that patient and that wound care center, the patient, as soon as they get that ulcer, they know they're not going to wait around as long and they're going to get into back to where they were seen. So they can get healed much faster the second time around because they know what to do and who to see right away. And so they might have to go down the same road again. Well, yeah, we're going to have to do the skin graft to get the skin sub because, we're in the same boat again. The patient has the same disease process. It might be a different spot. It might be the same spot. These kind of are lifetime patients. They re-ulcerate. It may not be it's great if it's up to a year, but you're going to see them back in a year to 2 years in general, if they still live in the same area. It's not unusual.
No, I can see.
To get to my venous ulcer talk, you're never going to get rid of those people.
I mean, the body's going to find a way to release that, whether it be a different foot or whatever.
Yes.
Yeah.
Yes. Okay. Yes. I brought up San Antonio for a reason. I mean, we're the capital for everything of all this complication. I'm glad we're located in San Antonio for the grafts because it's crazy. Okay, so I talked about
as well.
What's that?
I said I have a question as well. So you mentioned that in order to get the graft to actually get to the proper place of the ulcer, you have to increase the oxygen or circulation.
Well,
so
yes, they have. I'm sorry, go ahead.
Are they only using HBOT or what other forms of treatment are they using before Are they
Oh,
doing
not-
that before applying the graft?
No, no, I'm just pointing out, if you go into some of these clinics, they tend to have a hyperbaric chamber or they're affiliated with some type of hyperbaric chamber.
Okay.
Any good wound clinic should have some relationship with a hyperbaric facility.
Mhm.
I'm just kind of pointing out, if you do know they have a hyperbaric chamber, then you know they're already used to the idea of, oh, we gotta wait 30 days before we can even consider hyperbarics. And then if they have a busy hyperbaric clinic, then you know they're also got patients that are probably candidates for the grafts. And if they want the best outcome for that patient, well, your graft plus HBO would also be better.
Okay, I'm following now.
Yeah,
That makes complete sense. I used to work in
yeah,
a hyperbaric, so
yeah, great. So
yeah.
so you understand that, right? And you speak their language and they like that, right? So you're already saying, well, you've already got this patient that's a candidate for hyperbarics. They're also a candidate for your skin sub.
Yeah.
And that just, it's just another layer of, that they can help the patient. And they've already checked circulation. If they don't need hyperbarics, then they've already established, well, their baseline TCPO2 levels, right? Their circulation levels are normal. So they're already a candidate for the graft. They're not a candidate for HBO,
Okay.
right? So that's already in their decision making, right? It's go right for hyperbarics, go left for, okay, they have adequate oxygen, then we can do the next thing. So they're a candidate for a skin sub, and so that just changes things for them.
Yeah. Like that makes a lot more sense now. I see where you're going with that.
And then there's a third arm, right? Well, TCPO2 is terrible. It didn't respond to oxygen, so I can't even do a hyperbarics because their vascular status is so poor. We need to get a vascular intervention. And then so they have to get it bypassed with the vascular surgeon, get more blood flow, but the patient's too sick to go hyperbarics. Well, then I want a skin sub because at least I can optimize blood flow and do a skin sub. So why, we fit in that model, like, great, just just help them with that decision. Like, okay, yeah, let's do the next step. We're getting some more blood flow. Let's get the circulation going and we're ready for a skin sub.
That
Because
makes
we want to prevent amputation, right? The slide's gonna kind of lean into that too, in a second here.
yeah. Those patients probably wouldn't do well if it was amputated too.
Exactly. And I'm gonna, yeah, you guys are getting ahead of me, but you'll see. So again, the graft is dehydrated and it'll be applied to the wound bed, and the graft in most cases needs to be fenestrated, where they cut holes in it to allow the drainage to pass through it. Otherwise, it'll pool under there and it'll kind of lift the graft off. So you don't want that to happen. Okay. The good news is the graft is double-sided, so there's no wrong way to apply it, and this makes it easier to use in those undermining areas or tunneling. And in my experience, some of the other grafts can be bulky or a little thicker, kind of like cardboard. So it's a little difficult to conform to the wound bed. So the providers tend to like ours, where it's a little more malleable and incorporates a little better.
Hey,
So,
Ruben, when it
yes.
comes to really quickly, sorry. When
Yeah.
it comes to the graft, do they just lay it on and suture it, or they lay it on and just wrap it and then let it just, do its work?
So the way you
Or
adhere,
both?
you
I don't know.
you could just lay it on, but you want to secure it in some fashion. You don't have to suture it.
Okay.
You don't have to suture it. However, it is tensile enough to suture it, but the patient's not going to like getting sutured. I'll tell you right now.
I'm just thinking best practices for like outcome wise.
But you could steri-strip it, or you could do a little bit of the dermabond. You can tack it down a little bit. It just depends on the provider preference, but they're going to secure it probably with a steri-strip, like you picture frame it.
Gotcha.
Let's just say you put 4 steri-strips, on the edges, or make a picture frame around it to hold it down. Would be at least at minimum to kind of keep it down there. And then here's some talking points I kind of came up with as a provider. You have cost conscious staff members, in the clinic. They're like, well, your graft's expensive. And you got to kind of point out, well, what does it cost to take care of a patient with a diabetic foot ulcer? And on average, it's $28,000 per patient per year that has a diabetic foot ulcer. And if you could heal the wound in 2 to 5 applications, you could save the patient's foot and reduce their overall cost. So people don't tend to think, well, yeah, it's a lot of money up front, but think of all the money you've saved them and time uh, in the collective sense, right? You might be able to heal it for half the amount. It might cost $10,000 to do your 2 to 5 applications, and they're done. But you'd rather drag that patient over 120 days, weekly to the clinic. They're billing for the visit. They're billing for their debridements. I mean, nobody's telling them that, right? So I'm like, well, yeah, you gotta look at what are we trying to do? Close this wound as fast as possible, right? So clinicians typically don't see it this way. They just see the upfront costs, and so does the hospital usually. But once you start to see, like, wow, if I heal this wound, my days to healing has reduced significantly, then they're done. Patient doesn't have to come back for a while, and they do well. You save their limb, you save their life. In my opinion, that's just how I feel about it. And so let's talk about the standard of care, right? Standard of care is good. Patient comes every week, and this is where I'm kind of coming back to that average visit. Over 3 to 4 months, anything can happen, right? Infection invariably can happen. Wound deteriorates because they got to get drug out of the house and find transportation. Anything and everything can go wrong. Okay. And then with the graft, you can decrease the time it takes to heal. So you're reducing the complications overall because that wound is closed. The risk of infection that door is closed, right? And which makes the standard of care plus the graft even better as a marketing point or talk point. And so overall, the prognosis with a diabetic foot ulcer is good if you identify early and you treat it immediately. The delays in care can only have poor outcomes, okay? It leads to the hospitalization or a prolonged stay in the hospital and the subsequent amputation. And then the complications are pretty profound. You get the gangrene or the bone infection, and they end up with permanent deformities and risk of sepsis. The amputations, as mentioned before, you get the ray amputation, the transmetatarsal amputation, BK, AK. Yeah, I've even seen it go into they take out the whole hip and everything, the disarticulation. It's not pretty. And what I really want y'all to understand is when a patient has an amputation, the overall death, the percent, the range is 13 to 40% in the first year. This person can die. And then it creeps up. Within 5 years, they have a 39 to 80% chance of death. It's so impactful, and just understand where I feel. I'm passionate about limb salvage. It's something we can all help. Just give the patient every resource available to them. And educate these practices that, hey, the skin sub is another tool to get you to get this wound to close. And to understand that prevention is very important. And it's through patient education. Once they understand the disease process and know that what they do is going to impact their goals or their success, or failure, the patient can make the decision. Well, yeah, okay, I get it. I need to quit walking on this thing, and that's the hardest to prove to them that yeah, you don't need to walk 200 feet. It's the first 10 steps that are the problem, and usually it's to go to the bathroom. But if they just kind of understand, the fewer steps, the better, or have the right, put their boot on before they go, then they can do better. Okay. So,
hey, Ruben,
yes.
Quick question for you.
Yes.
I see the road you're going down because I've worked with a lot of vascular surgeons in the past, and it sounds like it would be they see a lot of obviously compromised diabetic patients, so they can atherectomy. The patient comes in with an ulcer, they can atherectomize with stent, balloon, whatever it is, make the arterial leg peripheral better, and then use our product after, and they become a hero. It sounds like.
Yes. Now you have to think too. Yeah, I wish it was that easy.
I know.
Yes, our product's going to help. Yes, I'm not disputing that. I'm just, there's also small vessel disease, right? So they're opening up large pipes, right? You know how you go to the faucet, you're going to turn on the faucet, you got the large pipes, right? But at the filter at the faucet, that's where the capillaries are, and you get that calcium buildup, and that slows down the stream. So the small vessel disease is the patient's enemy as well. So that's where our graft comes in as well, because even though they have the large blood flow going, it's still going to trickle down into the small vessels that are also gummed up, right?
Oh,
So
I see where you're going. Even though you could like clear the SFA, it's like we still have now a
yes,
lot of
now
different areas that are
that's good because they're getting the fire hose going, right? We open the
right.
fire hose, right? Boom. But we still are going to have, we're still going to run into problems. So just kind of they
No,
should,
I can see where you're going with that. No,
but
that's awesome. Opens up a lot of windows and doors.
correct. And yes, that's the next step. So they did do the revascularization. Well, yeah, now they're ready for graft because you've optimized them as best you can. They can't do anything about small vessel disease. So now they're ready. They're going to do even better when you apply the graft, right? Um, or you can also do graft plus hyperbarics. I know I'm always a hyperbaric stance, but it's a great resource as well. I think they do well together. You want the patient to have the best outcome, right? And so that's where I go with everything, you know. So then, and there's also other places that they would sometimes those vascular sites they have trouble healing too. I've seen some of those roback groin wounds from those vascular interventions. They go bad, and these grafts can definitely help in that area too, on the surgical side. Um, so then let's kind of get back. Talked about the complications, and then the post-op care. Usually, patients end up with amputation. They need PT, OT, a prosthetic, um, and just understand. You know, it's a team approach. You know, you mentioned the vascular surgeon. There's the PCP, the podiatrist. These are all the gatekeepers, right? Case manager, social workers, home health, um, and you know, as a rep, you're also bringing new information to the providers. A lot of times they don't get away to go to these conferences. They can't, you know, they just don't have time. So bringing them, you know, this product information and letting them know, yeah, this is what's going on. They welcome that. I know sometimes it's hard getting through the front door, but those are questions you could ask them. Well, hey, you know, do you guys offer hyperbarics? Oh, great. So then you could say, well, you know, and let me understand hyperbarics. It's, you know, the patient has to have a wound for 30 days and then they're eligible. Said, oh, okay, great. Well, you know, with our grafts, if a patient has a wound for 30 days, they're eligible for the skin sub. And you might have patients who don't qualify for hyperbarics. They might benefit from the skin sub, you know, because for whatever medical reason they can't go in the chamber. Maybe they have a pacemaker that's not rated for the chamber. Maybe their lungs are bad, or you know, whatever reason. Uh, well, they can still get a treatment that could still help their wound. And you know, those are talking points I would bring up maybe. Uh, if they're open to listening, you know, having a conversation just like that. And that's how you do a segue into it. Like, well, yeah, you know, so this graph, and then you can kind of give them some info and go that way with it. And then just understanding that prevention is is the most important, right? Foot care, no smoking, make sure they keep their appointments, and just keep reinforcing it at every visit. It's so crazy. And just kind of in summary, you know, key is education, team approach is crucial, and you're part of that team. And treat an infection early, and above all, prevent infection, amputation. I threw some pictures together. I did a week. This is like a week for me, right? So there's a Wagner 4. There's some 3s. Definitely could benefit from some stuff. But you know, this is things that you would typically see in a wound clinic.
Hey, Ruben, is it? I think I might have talked to Tim a little bit about this, but I wasn't sure about for off-label stuff? I mean, obviously docs can do what they want, but you have to let them know it's off-label. But is it strictly external, or can you internally do this? Because those are some gnarly wounds.
Yeah, yeah.
Could they put it in and then suture over the top, or is
No,
it just
no.
kind of an outlaying thing and then bandage it and put a cast on and I'll see you next week?
Yeah, this would require a good offloading, and some of those. Well, like if it's the top of the foot, they wouldn't necessarily have to have the cast. The plantar one you would. Um, Again, it's convincing the patient to wear a cast. That's another battle too. But all these are applied externally.
Okay.
I can't speak to the internal side. I think there might be something coming out later. I'm not sure. Quentin might be able to answer.
So yeah, so these grafts that they have been used in like the Da Vinci robots and stuff like that for GI surgeries, OB stuff. So yeah, they can be used internally as well.
Awesome. Any other questions?
Guys, I wanted to jump in real quick too. A lot of times like I get the question of, where's the best plan of attack to start targeting some business. So like Ruben stated earlier, just in the San Antonio area, 1 in 6 people here have type 2 diabetes. There's about just a little over 1.4 million people, I believe, in the San Antonio area. So about 240,000 of those people have diabetes. And we are talking about one very specific wound for one very specific patient type. Of those people, probably, I don't know, I'd say close to 15,000 people just in the city of San Antonio have diabetic foot ulcers. That's not counting your burns, your pressure ulcers, your cuts, your other non-healing wounds. So when you're kind of trying to drum up where to maybe start targeting some of this business, this is a very good place to start looking on your podiatry side, because your podiatrists and obviously your wound care guys are the ones that are seeing this firsthand. A lot of times, the home health guys, because these wounds do get so bad that a lot of these people don't have the ability to get back and forth to the hospital, every 7 to 10 days to change a wound graft out, or to reapply a new wound graft. So a lot of these people are utilizing the home health aspect of things. So podiatry and home health, just speaking on behalf of this call, are two really good points to start looking and drumming up some business there. So if anyone has any questions, Ruben's wide open to answer them. So feel free.
No, I did have a question actually for Tim, for you and Ruben. I know we've talked about a lot of call points, obviously vascular, wound care centers, podiatry, things like that. Any ones that you, Ruben, that are like ones like you make sure you walk into this office and cold call it because they could easily use it? I'm just curious about other call points other than like general surgery and podiatry and things like that.
Yeah. Do you have access to a hospital or like the case management department?
One of my really good friends is a vascular surgeon. He has like 4 offices, so he's like the first person I'm going to go talk to.
Okay.
Because when I was in Medtronic doing like arterial peripheral vascular stuff, it was like I could see him doing that stuff, and he was like, "Oh, this thing doesn't work well." When you talked about it's not as rigid as a product, and it's very formable, I was like, "Oh, he's gonna love this thing." So I was like, I'm just thinking outside of the box for the crew and for myself.
No, perfect. Yeah, I mean, definitely. Vascular is a good way to go. In my experience, they don't do a lot of wound care per se. So I'm glad this guy, if he's able to use the product, that'd be awesome. They're all about endovascular stuff. They don't want to mess with the wounds directly as much. So
Oh, okay,
a
interesting.
lot of them try to. So I mean, it's just kind of the politics in my area. I don't see a lot of wound care vascular surgeons.
Probably right. I think he probably will stent it and then refer it to somebody else. I got you.
Yeah, yeah, they go for the high end stuff and they leave us the
Yeah.
the boo boos, if you will.
Yeah, actor recognizes everything. He's like, throw in, I'll hawk this thing, and then you're out of here. And the lady, I can feel I can run a marathon. It's like, well, not yet.
But occasionally they get
ulcer on your foot.
but occasionally they get stuck with their chronic non-healing surgical wound site, and that's also an opportunity. Well, hey, you know, this, especially if it's a real obese patient and he thinks that he has, they're too big to close them. Sometimes they have to just do like they still have to kind of leave it open. So that would be a perfect opportunity to apply the graft in that situation. So it just kind of, maybe just have that conversation with them and see if it can definitely help them out. But what I was getting to is, if you have access to a hospital like case manager, and they're always in touch with home health, and you could be like, well, who do you use for home health? And because they already know who works and who doesn't. And wound care centers too. You could be like, well, hey, do you guys, what wound care team do y'all like for home? And they'll be like, oh yeah, we like these guys. We use them all the time because they get back to us. They don't try to change our orders, and so you can kind of reach out with them and see if they have a specialist, or just kind of network that way if you want to make a foot into the home health side for the patients that are in the home. Well, they're kind of attached to the wound clinic, but it might be on the case management hospital side where those patients are more stuck at home. You know what I mean? So
what
just
about like
kinda-
the senior kind of living spaces? Instead of having to refer out to a hospital, they like can keep it
yeah,
in.
that would be a great opportunity as well, because that's their home. So that's definitely a home setting.
Definitely don't want to leave their room. So okay, good to know.
But yeah, you just have to kind of figure the segue into that, because I think they're real protective too about who kind of walks in there. So just maybe, yeah, but yeah, you could definitely.
Yeah, I see where you're going. You can ask, but it's like, yeah, pressure too much.
Yeah, you might have
See
to
what
be
you're doing.
yeah, somebody you know would kind of need to invite you in, just to make it, it's a little easier that way if you can get invited in. I, when I did home health, or I did nursing homes for a while, and I was going out, my colleague was like, yeah, I got this nursing home online, and it's now, I need you to go next week. And I said, okay. So I just show up the next week, and they're like, well, who are you? And I'm like, well, I thought they talked to you about me. And like, just you just want to, you don't want to just roll up somewhere and not not have a plan, or them not know you. It's kind of, they get real protective from that kind of stuff. So just just be careful when you're in those settings.
Tread lightly. I got you.
Yeah, it's great. You just gotta just make sure you're get a little funny.
So Ruben, who, like, in the nursing homes and home health, who are like the gatekeepers when it comes to the grafts? Is it the nurses that have the ability to change the graft? Or would we connect them with their wound care, like who they're seeing for wound care?
Yeah, there would need to be a provider of some sort, doctor, nurse practitioner. Invariably, it'll be a wound specialist. Well, I'm going to use that term loosely. There will be a provider that's a wound specialist. I'm finding there's some providers that are not even wound specialists putting on things. So just some home health are actually partnering with some providers that are using the grafts. So they might be able to let you know who they're using, and maybe you could reach out to them and offer them, this particular product.
Okay.
And go ahead.
So we're connecting with, if that's the route we're going, our goal would be to connect with whoever they're teaming up with to do grafts.
It's
As far as like the primary provider.
Yeah, and typically, and Ruben, correct me if I'm wrong, that they usually have people contracted for their facility. So somebody like Ruben, who works at the hospital and does wound care, they would contract to come do their wound care in that facility. Now, on the sales side of things, you want to make sure of one thing. There's Medicare Part A facilities and there's Medicare Part B facilities. So the Medicare Part A facilities, how those typically work is is they are given a lump sum of money that they allocate out to all of their services, everything that they include in their facility. So our grafts are different there because most of them will purchase grafts directly. So it's not, I guess, reimbursable is the word for it, because they're paying for grafts directly when they're using grafts. Medicare Part B, they're the ones that are actually going through the reimbursement process where that $9.50 per square centimeter comes into play. So just be cognizant of that if you are targeting these nursing home and assisted living facilities. Medicare Part B is the focus for what we're doing.
That's helpful. Thanks, Tim.
Hey, you guys, is there a lot of pushback? Obviously, Ruben, you've talked about obviously clinics and private practice, but hospitals you mentioned as well. Obviously, being in a hospital setting, they're going to be like, are you on contract? Have you gone through the VAT committee? Do you get a lot of pushback on that? Or is it more like the doc kind of goes like, this is what I want for my patient. It's the best thing for him. And I could, price wise, we're right in line and let's bring it in and put it on the shelf. Or is it kind of like pushback? I mean, COVID ruined it, but you know what I mean?
It's helpful to have the doc be a big proponent of it, of wanting to get it in, and then it makes the legwork a little bit easier, in my opinion. Because I don't know how you feel about that, but it's always been my experience when the doc pushes harder, it helps.
Oh yeah.
Yeah, I mean, a lot of times these patients can't advocate for themselves because one, insurance is extremely confusing for everybody and probably most so for the patient. So yeah, I mean, having the doc on your side or their side is always key for that.
Question from me. I know you talked about diabetic foot ulcers today, but this applies to a range of different wounds, right?
Yes, there's more to come. This was today's topic. I got venous ulcers next. And just as intense. We're going to talk about all types of compression.
So Ruben, I mean, obviously you just said that. So arterial and venous, it doesn't matter if you have an ulcer or if you have a wound. I mean, obviously the skin substitute doesn't matter if it's venous or arterial or whatever it is, right?
Correct.
Okay.
Right. As long as there's no yeah, it can't be an obvious defect of some sort. It's pretty much your chronic non-healing wound is an umbrella.
And that's kind of the protocol for the providers to be able to use these grafts is a non-healing wound that has gone through standard of care for at least 30 days. So that can be any non-healing wound, regardless of what it's from. If they fell off their porch and scraped their leg and, they're of Medicare age and their leg is not healing within 30 days, then those people are eligible for a skin substitute. And then you have obviously people like this that have more underlying problems like a diabetic foot ulcer, those and everything in between.
What about patients with pressure ulcers, especially those that are spinal cord injury patients? They tend to have a high rate of incidence with pressure ulcers. Would this be applicable to them?
It would, yes. So as long as it's a non-healing wound, 30 days. Sometimes we see those in populations that aren't necessarily Medicare populations yet. Those patients usually will lean more towards like a hospital surgical graft that sometimes insurance will pick up on that side of things if they've been in the hospital for an extended period of time and have a pressure ulcer or something. Otherwise, if they're already out of the hospital, again, and Medicare's our main focus with this kind of stuff. But yes, those would be covered as well.
And it does well to cover some of those bony areas. You get some exposed coccyx and everything when the wound bed's got a long way to go. That can definitely speed it up. So if your surgeon is on board, and they'll roll with it. They're going to be very impressed by it.
Any other questions from anybody?
I do have one question. I know we've talked a lot about Medicare, so I'm assuming Medicare is the only insurance that will cover or reimburse. So this would only be for older patients. That wouldn't apply to patients that are like in their 40s or anything like
So
that.
on the wound care side, yes. And that's not just for our graft. There aren't any commercial insurances out there that cover skin substitutes across the board.
Okay.
So that this is common. This is known in the wound care space, and all the guys that you're going to be dealing with, podiatry, derm, all of these guys already know that stuff as well. But yes, this is a Medicare focus. Now, obviously on the ocular side of things, the surgical side of things, where prices are negotiated directly with the facility, that's everybody across the board. But for wounds specifically, main focus is Medicare.
Okay, that's good to know. It's a huge learning curve. It's unfortunate though too for those younger patients.
It really is, because, you know, like Ruben was saying, that a wound care graft can help a patient, you know, heal so much faster than just something. Because I mean, how many patients out there have diabetes, for example, or a diabetic foot ulcer that aren't 65 yet? Probably more so than have hit that 65 mark. But, you know, unfortunately, it's an insurance thing, and you see it across all spectrums. I mean, you see it in the pharma world, you see it in you know, this kind of setting. Unfortunately, insurance is what it is, and there's nothing that we can change about that. But yeah, it's an unfortunate situation, but you know, we definitely want to try and help all the ones that we can that are of that age at least.
Exactly, yeah.
Is there any hi, it's Greg. Is there any differentiators from the standpoint of people that aren't covered by Medicare that our skin grafts stick out above the competition, even though it sounded like you said ours are more expensive?
I don't really understand what you're asking. Like commercial insurance, you're saying?
Yeah, well, is there any other differentiators if somebody's not covered by Medicare and they want to use skin grafts, right, and they're going to be paying out of pocket, is there anything that sticks out from us, that differentiator that's different from what's out there right now in the market?
I mean, if you get into a scenario like that, we can definitely talk one off. I mean, we have a surgical line of graft that we can sell into a facility. It's going to be different than what you're selling into like a wound care or Medicare space. But if you come across somebody that's interested in cash pay grafts, then yeah, we can definitely talk one off. And that's for everybody. If you guys come across anybody that's doing this stuff cash pay, then we can talk about that aspect of things if they arise.
Thank you.
Yeah, I was thinking about the whole aspect of just because I've dealt with insurances with other companies, and it's like, okay, Medicare they can deal with, they're actually pretty cool, but it's like Anthem is a pain to deal with. Are they cool with covering it, or is it a pain for the patient and the practice and the docs?
No, so everyone that you're going to deal with on this side of things is well versed in the Medicare market. And like I say, what they do is they know if the patient is covered on Medicare when the patient comes in that first time with, say, a diabetic foot ulcer. They'll come in, they'll analyze the patient, they'll run the insurance, they'll see all of that. Most of those practices will make note if the patient is Medicare eligible and can receive a skin graft. Day 30, when they come back and it's not healed, they set them up typically 2 or 3 days later for graft application. During that 2 or 3 days on our end at Revigen, we're doing another insurance verification and sending out that graft. So say they see a patient on day 30, which is a Monday, they have a non-healing wound. They reschedule that patient for a graft application on Thursday. We get the insurance verification on Monday. green light everything on our end, overnight them the graft's sitting there waiting for the patient when the patient comes back for graft application on Thursday.
Gotcha. Now, are we doing, well, the practice is kind of doing the whole insurance side of it. Do we get involved in that, or they just go directly, to Revigen and go, well, this is what we need. This is the patient. Here's the information. Or are we getting involved into that insurance aspect of it?
They'll send that directly over to us. Now, if you're involved with the office, a lot of reps, what they'll do is once they get an office on board, they'll be in that office, say, every Monday, and they'll have an idea of all the patients and help the office. Okay, well, let's get this sent over to Revigen. Let's get these ordered. Whoever we're going to apply grafts to on Thursday and Friday of this week, that it's a scheduling side of things. So yes, you can be involved in that, or you can walk the office through just sending, it's a one-page verification that they send over to us. And then we run the insurance verification.
Oh yeah, I've seen the one page. Oh, that's true too. And that's a great way to build that relationship with the account. It's like, hey, I'm looking out for your patients. You have Mrs. So-and-so coming in, and oh, that's right, I forgot to order that. So, okay.
Yeah. And those guys appreciate it too. Like I say, once you get somebody on board, those offices become very appreciative if they know they're going to see you every single Monday and you're going to help them walk through, whatever patients they have for the week, make sure, things are filled out and ready to go. Because a lot of these offices, they'll be applying grafts to, 10, 15 patients a week, on Thursdays and Fridays, and Mondays are their order days. So if you're in there on Monday and just to be an extra set of eyes, then those offices definitely appreciate those things.
That's a great way also to like, hey, stock your shelf just in case.
All right, guys, if nobody else has anything left, I'll go ahead and stop the recording of this. I'll send this out to the group, this presentation. I'll have Ruben send me over his slide deck as well, so you guys will have both of those in your inbox. The ones that have not onboarded yet, or those of you that might need a refresher and some help with onboarding and filling out forms and everything, there will be an onboarding call with Tim tomorrow at 2:00 Central Time. Let me know if you'd like that Zoom link. I've already sent it out to our new folks that are getting started this week. And then Friday, Dr. Stickler will be giving a presentation as well over Mohs surgery. So feel free to join that. I'll record that one as well and send it out when the time comes. But if you have any questions, we're here. So let us know if you guys need anything.
Hey, Tim, quick question here.
Thank you, guys.
Thank you.
Yeah, Tim.
Sure.
Yeah, just real quick, going back to the insurance side of things. What about the arena and work comp